the Moore Foundation was trying to decide what we could do. And one of the strategies that we had was to start field building a community of people with the right skills and the ability to make the change. And it seemed like a very natural partnering with the national academies, and it aligns very well with the concerns that the National Academy had from the 2015 report, Improving Diagnosis in Healthcare.
When I was a resident working in the intensive care unit, I had a patient who we brought back from the brink of death, and he was ready to transition out of the ICU because he was better. And I was shocked and saddened when 2 days later, he was back in the intensive care unit for something that was totally missed by our team and the team before that. And I kept thinking to myself, how could we have missed this? How could we have communicated to the other team better that we weren't quite sure why he was better in some respects, but not in other respects? And for me, that was kind of the journey to focus on how can we make the diagnostic safety process more explicit and communicate about it more explicitly, clinician to clinician.
It's about getting our patients, particularly in my case, birthing persons, the right diagnosis at the right time and being able to communicate that diagnosis. And so being able to have an approach to maternal care that includes diagnostic excellence means that we're able to recognize emergencies, respond to them appropriately, and provide a respectful birth experience.
Unnecessary antibiotics cause harm. And for years, doctors have been working to try to prescribe antibiotics better, and they keep hitting roadblocks. The approach we've taken is to work upstream of that and say, okay, if at the moment you decide to prescribe antibiotics, you're potentially making an error or doing something where the risk is gonna outweigh the benefit, and for whatever reason, whatever we try to do to affect that decision is not gonna work, maybe we can change the way you ordered the test that led to that decision.
There are disparities in diagnostic errors, including patients, vulnerable patient populations like patients of color. And it was important in our advisory panel that we sought out a really diverse voice set. So we had patients, advocates, and family members from various racial and ethnic backgrounds, specifically because we wanted to understand what are the barriers to patient engagement, especially from historically marginalized and disempowered patient populations.
So we know that the COVID pandemic had disproportionately impacted Latino Hispanic communities, and already the population was impacted by disparities in lung cancer outcomes. So a lot of those outcomes, disparities can be bridged through early detection and access in lung cancer screening, but many of our Latino Hispanic communities are not benefiting from these new technologies. So what we want to is incorporate the Latino Hispanic community voice into outreach campaigns to ensure everybody participates in lung cancer screening.
A lot of my work involves developing data-driven models. But as part of the program, I've also spoken with patients and their parents, hearing their stories and seeing the synergy between what they tell me and what I find in the data. That I find very exciting, and it provides validation of my work. And also, when I speak to the patients and the parents, to know that our work is making a difference in their lives, that excites me.
I think we'd like to see a generation of committed talent that helps the world acknowledge the importance of diagnosis, not just treatment, and that sort of leads to a renovation in healthcare. Rather than denying the problem, we can not only acknowledge it, but we can start chipping away at really effective solutions.